We're all set. Thank you.
Board Member Doyle speaking. We now resume the Oregon Board of Pharmacy meeting for April 11th. So approximately for the next 2 hours until 12 o'clock lunch break, we'll be reviewing rules and this related discussion. We will begin our rule review and that discussion starting with Staff Member Davis. And we will be reviewing mailing C as in Charlie.
Staff Member Davis. Okay, before we dive into discussing the proposed rules, I want to provide the board with some context. Board, you recently adopted 100 rules. I went back and counted them. It's exactly 100 across 5 new divisions, which all took effect on March 1st, 2024. These rules aim to bring clarity to both for our future and our current licensees regarding compliance with the law. I'm happy to report that out of 100 rules, agency staff so far have identified minor issues with only 4 of the rules, which we're going to be discussing shortly. We'll be doing mainly C, C2, C3, and C6 are these rules that we've identified. We will discuss these issues in more detail when we cover each of the rule packages. The proposed amendments to these packages are essentially cleanups. They involve small edits that we noticed after the rules were adopted, but before they became effective. But the edits weren't significant enough to warrant a temporary rule, nor did they fall under the category of a minor correction that could be allowed without the full rulemaking process. So in short, the initial rulemaking process, which involved a year of board review, modification, and public comment, has proven successful. Out of 100, only 4 so far need minor adjustments. This reflects the thoroughness of your process. And while we may identify further refinements in the future, we commend the board for your work and your dedication to this important task. Additionally, as you know, our agency has produced 3 online informational programs about these new rules. We've had over 850 completions of these programs. And Phone Duty has consistently fielded a few questions as a result of people going through those programs and learning about the new rules. However, none of these inquiries have necessitated a rule modification. So we didn't, I was worried, right? We're going to get to March 2nd and we're going to start getting all these phone calls because people started reading the rules. And so far, we have 4 for you. So with that, we'll go to mailing C. This is the board's first review of this rule repeal. In August 2023, the board adopted this rule in OAR 855-115-0200 outlining PIC qualifications and limitations, and it was set to be effective on March 1st, 2024. However, the rule lacked requirements for the pharmacist in charge positions between March 1st, 2024 and July 1st, 2025, and had no limitations for the PICs at all in the rule. So recognizing this issue, the board adopted a different rule, OAR 855-115-0205 in December 2023, which was also effective on March 1st. So we have 2 rules that are effective with the same title. The newer rule includes those missing qualifications and limitations for PIC. And so it essentially supersedes the rule that's also on the books at the moment in OAR 855-115-0200. Therefore, repealing this rule eliminates unnecessary and potentially confusing overlapping information. So at today's board meeting, the board will consider sending the permanent rule repeal to the May 2024 rulemaking hearing and potentially adopt in June to be permanently effective upon filing. And you can see the language is just to completely strike the rule as you have another rule in 0205 that says all the same things with a little more clarity and the added limitations. Back to you, Board President Doyle.
Board Member Doyle, thank you for the presentation. We open discussion with Board Member Chin.
Member Chin has no comments.
Board Member Joyce.
Joyce, no issues.
Member Patel.
Patel, no issues.
Member Hemmons.
No issues.
Member DeBarmore.
No comment.
Member Hall.
Member Hall, no comment.
Member Beeman.
No comment.
Member Doyle, no issues. Is there a motion to move to send proposed rule OAR 855-115-0200 to the May 2024, to the May 22nd, 2024 rulemaking hearing.
So move board member Chin.
Second, board member Joyce.
Motion has been made by board member Chin, seconded by board member Joyce, so I'll call roll. Board President Doyle, yes. Board Vice President Chin,
Yes.
Board Member Beeman,
Yes.
Board Member DeBarmore, Member Hall,
Yes.
Board Member Hemmons, Board Member Joyce,
Yes.
Board Member Patel.
Yes.
Motion passes. And this motion, this OAR will be sent to rulemaking hearing in May. I turn it back to staff member Davis to review C2, Charlie 2.
You said this is in C2. This is about short-acting opioid antagonists. The board is conducting its first review of a proposed rule amendment to address a gap in the current regulations. Currently, the exemption from labeling requirements for short-acting opioid antagonists is too broad in our rule. It encompasses all forms of the medication. This revision aims to limit the exemption to specifically to nasal sprays, which will align the rule with Senate Bill 2023 Senate Bill 450 and ORS 689-813, which is what staff member Melvin is pulling up on the screen for you right now. 689-813 in paren 1 says a requirement that a healthcare provider who is authorized to prescribe drugs in the state label a drug dispensed by the healthcare provider with the information described in subsection 2 does not apply to a drug approved by the United States Food and Drug Administration for the reversal of an opioid overdose if the drug is A, in the form of nasal spray, and personally dispensed by the healthcare provider described in the subsection at the location of practice of the healthcare provider. So we can switch back over the mailing. At today's board meeting, the board will consider sending the permanent rule repeal or permanent rule amendment to the May 2024 rulemaking hearing to potentially adopt in June to be permanently effective upon filing. And you can see on second page on line 24, it is just adding the limitation that this is the pharmacist is not required to label the prescription according to OAR 855-041-1130 if dispensing an FDA approved short acting opioid antagonist in the form of a nasal spray. Back to you, Board President Doyle.
Member Doyle, thank you for your presentation. Board Member Joyce, questions or concerns regarding mailing Charlie 2?
Board Joyce, well, do we have an issue with how healthcare provider is defined, or is that just the broad term? Care provider, it doesn't need to be any more specific than a healthcare provider, is that correct?
There is no definition of healthcare provider in ORS 689, so it is left open. We don't further define that.
Okay, I mean, just didn't want any, thing to come up and say, oh, what is this definition of, okay, I'm fine.
Member Patel?
Well. No comment.
Member Hemmons?
No comment.
Member DeBarmore?
Member DeBarmore. Is there any implication in a remote dispensing site? Missing a pharmacist.
Hey, hold on. So the law requires that it only has to not, it can only be exempted from labeling if the person who prescribes it is personally dispensing it. And in that case, in an RDSP, the pharmacist is not personally dispensing it.
Wish that, thank you.
Member Hall,
Member Hall has no comment.
member Beeman. Member Doyle doesn't have anything to add. Board member Chin.
No comment.
Is there now a motion to move to send proposed rule OAR 855-115-0350 to the May 22nd, 2024 rulemaking hearing?
So moved, board member Chin.
And then board member Joyce?
Motion has been moved by board member Chin, seconded by board member Joyce. I will now call roll call. Board president Doyle, yes. Board vice president Chin,
Yes.
board member Beeman,
Yes.
board member Barmore. Member Hall,
Yes.
member Hemmons,
Yes.
board member Joyce,
Yes.
member Patel.
Yes.
The motion passes and this will be sent to the May rulemaking hearing. I'll move on to presentation and discussion with regard to C3, that's Charlie 3.
Member Davis, this is mailing C3, intern prohibited practices. The board is conducting its first review of a proposed rule amendment to address an inconsistency in our current regulations to align with OAR 855-115-0145, which is our pharmacist counseling rule. This proposed amendment clarifies that a supervising pharmacist who is also fluent in the language being interpreted may communicate directly with a patient who prefers to communicate in a language other than English, or communicates in a sign language without mandating the use of a healthcare interpreter registered by the Oregon Health Authority. At today's meeting, the board will consider sending a permanent rule amendment to the May 2024 rulemaking hearing and potentially adopt in June 2024 to be permanently effective upon filing. You scroll down to the rule language, this is under prohibited practices. An intern must not, and it says communicate with a patient who prefers to communicate in a language other than English or who communicates in a sign language unless the intern is a healthcare interpreter registered by the Oregon Health Authority under ORS 413558, or the supervising pharmacist or preceptor is also fluent in the language being interpreted. We accidentally limited in this rule that it could only be a preceptor who's supervising an intern that would have this exemption, and it should be any pharmacist that is supervising an intern, because they're already permitted to do this in Division 115. Back to you, Board President Doyle.
We'll begin questions and discussion with the board member Patel.
Patel, no comments.
Member Hemmons,
Member Hemmons, no comment.
member DeVarmore,
No comments.
member Hall,
Member Hall, no comment.
member Beeman,
No comment.
board member Doyle. Appreciate the passion and clarity on this rule revision. Board member Chin,
Comment.
member Joyce.
No comment.
Therefore, is there a motion to move to send proposed rule OAR 855-120-0150 to the May 22nd, 2024 rulemaking hearing?
Board member Chin.
Okay, then board member Joyce.
The motion has been moved by board member Chin, seconded by board member Joyce. So we'll now call roll. Board president Doyle, yes. Board vice president Chin,
Yes.
board member Beeman,
Yes.
board member DeBarmore,
Yes.
board member Hall,
Aye.
board member Hemmons, board member Joyce,
Yes.
board member Patel.
Yes.
Motion passes and this proposal will be sent to the May rulemaking hearing. We now move to mailing C6, that's Charlie 6.
Staff member Davis, staff member Melvin's gonna pull up the law so we can have it up on the
You
screen.
mentioned that that's gonna be on the Friday part of their public agenda.
Yeah,
'Cause this mailing, it was
This one
out of order,
that I'm
right?
about to do.
Correct.
And then.
We weren't slated to look at it.
Sorry, there's two things going on in this conversation. All right, for the board to be aware of the motion related to this.
No, just
Yeah.
so the public knows that this mailing is labeled on Friday's agenda.
Oh, this mailing for the public is labeled on Friday's agenda. So we are doing it today. We are moving around, just so the public knows. We're doing C6, which shows up on Friday on the agenda that was noticed. Thank you. It's very confused there. All right, so this is Division 115, pharmacist responsibilities. This is when they're practicing pharmacy for a drug outlet, and it's specific to the rule that's in this section on delegation of final verification. The board is conducting its first review of a proposed rule amendment to OAR 855-115-0130. The current rule allows a technician performing final verification to do more than the law permits. The revision aims to fix this by making the rule match the law, which was 2022 House Bill 4034 and ORS 689703, which is what staff member Melvin has pulled up on the screen. Specifically, the current rule permits a pharmacist to delegate to a technician the final verification of the drug and dosage form. The law, however, only allows a technician to perform final verification of the drug and drug dosage, not the dosage form. We got the rule language correct in the technician division of rules. I'm not sure how I missed this. So it's already correct over in Division 125. It says a technician can only perform final verification of the drug and drug dosage, but somehow in the pharmacist, it said dosage form. So we need to fix that. So staff member Melvin is scrolling down on line 61. When engaging in the practice of pharmacy per ORS 689, each pharmacist may delegate final verification of drug and drug dosage, device or product to a certified organ pharmacy technician or pharmacy technician per ORS 689005 when the following conditions are met. There are no further changes to the rule, just fixing the language to be identical to the law. At today's board meeting, the board will consider sending this a permanent rule amendment to the May 2024 rulemaking hearing and potentially adopt in June to be permanently effective upon filing. Back to you, Board President Doyle.
Member Doyle, thank you for the presentation. We've been in with comments and discussion with board member Hennis,
Nothing to add.
member DeBarmore,
Nothing.
member Hall,
No, the whole nothing to add.
member Beaman,
No comment.
board member Doyle. I was trying to think about this in operational. I appreciate the need to match the law, and I don't have any issue with that, but I was, and thank you for also pointing out that it is correctly matching the law in the technician's form, and we're fixing the pharmacist area. But I was just trying to operationalize this and how I would operate it in the pharmacy. And if I were following the rule as it is, quote unquote, incorrectly transcribed, would you agree, or what are your comments that, if I were, if the prescription read sulfamethoxazole trimethoprim in a pill form, and it was filled with the pill, then I, as a technician, could verify that in the final verification. But if the prescription said sulfamethoxazole trimethoprim suspension, and it instead was filled with the pill, which is a different dosage form, then I, as a technician, couldn't perform final verification on that. I guess I wanted to understand with the intent of the law, which we're translating into rule, what is the effective way to operationalize the law in the pharmacy? And if Staff Member Davis has any comments on that or other pharmacists on how they practice, please let me know. Member Joyce.
Board Member Joyce, yeah, that's the first thing that came out, to me as well. When we're talking about dosage form, it could be the difference between a tablet and a capsule. Fluoxetine, 20 milligram tablet, fluoxetine, 20 milligram capsule. That's what I think of with dosage form, as well as tablet and suspension, different forms, that dosage forms. Also, when it comes to drug dosage, I usually, the first thing that comes to mind is the final dosage. For example, a 20 and a 10 milligram tablet ends up being a 30 milligram dose. And that's what operationally, that's what's, I understand it to be, that's the dose. Dosage form is the differences between injectable, suspension, tablet, capsule. I mean, we are in a profession where exact specific specificity matters. And we try to eliminate any kind of gray as much as possible. It needs to be black and white, tablet, capsule. So those are the things that come up and draws attention to my eyes, those in terms of dosage form. So I think that needs to be addressed because it doesn't seem clear, and it didn't seem clear to me at first glance as well. Thank you.
Board Member DeBarmore.
Board Member DeBarmore, and going back to what I believe the intent of what the legislation was to make sure that screen says, okay, in this bubble or in this bottle is lisinopril milligrams. And it is exactly that. It's not that the prescription that was written said, yes, Cetera suspension, but the pharmacist through their processes changed it from one dosage form to another. It's that the end product, when it's gotten all the way to the end, that's what the check technician is verifying, that what it says is supposed to be in this bottle or in this bubble is exactly what's in that bottle or in that bubble, and nothing else. There's nothing else to be verified. So there's no, should this be a capsule? Should this be a tablet? Asian judgment. Right. Does it match exactly what it's supposed to be?
Board Member Doyle. So another example I thought of is diltiazem SR versus CD. And let's just it's the first thing that came to my mind for an aging pharmacist. But my point is, let's don't quote me on this. Let's say both of them come as 120 milligrams, and if during the final verification, there's diltiazem 120 milligrams, but let's say it was supposed to be an SR, but it's actually CD. The technician is saying, yes, this is diltiazem, this is 120 milligrams, but it's still not the correct drug in the bottle.
This is Board Member DeBarmore. If a technician is there, we have so much technology now that if a pharmacy is only utilizing just what it says without NDC verification, or NDC plus visual verification, I think there's a little bit bigger issue there. So still, that would be judgment, and the pharmacist should not be delegating that particular prescription to a technician, right? There should be some way that it is exact. The technician is able to exactly identify and doesn't have to guess. Is this what I think they meant? And if the technician feels like I have to guess, then they should not be verifying that prescription. They should send it back to the pharmacist because they don't know, right? That's where a technician has to use have to draw their own line. Like, I can't interpret this prescription. I can't read what it says. I need to give it to a pharmacist to help me. I don't know if I'm forming this final verification correctly. I need to get the pharmacist to help me. Those are the things that you have to make sure are occurring, but that final verification is there's a pharmacy that's not using an NDC or visual verification for that final check. Okay. Is there a thing? Is there a pharmacy out there that doesn't have that? Have you all seen it in your inspections?
There are.
There are.
Yes.
There are. They don't even have NDCs they're verifying against. Then they should not delegate to a technician because that is judgment.
So, yeah, Board Member Doyle, thank you for the conversation and just trying to have board members speak on this topic and so on the record so that we have our viewpoints on how we are known how this would be implemented. Thank you.
Remember, Joyce, so in my experience, previously when it was check tech, was that we used technology to help to aid in the process of one technician checking another technician's work before going into an automated dispensing machine like a Pyxis machine, so forth. So the process was that when a medication is received, it's the pharmacist that verifies that it's the correct drug and it's put into stock. And then a technician would pull it off of stock, again, using technology and place it for another technician to check. And then it would go into a dispensing machine. This was pre-2020. And of course, we've changed a few things since then legally. But so my concerns are when it comes to dosage and dosage forms, and release enteric-coated lithium, right? You have lithium delayed release enteric-coated. You have lithium continuous release. You have Depakote. You have all these high-risk medications. You know, if you don't have technology helping you there, there is a risk for error, mistakes to happen, and that's a patient safety concern, obviously. Now, are the technicians going to be checking insulins? You know, are they going to be checking U500 concentrated insulins? So it's a big issue, you know, for the pharmacist. And they want to make sure they have the technology in place and the training in place. This is where education training for technicians is very important. To know the differences of extended release, to know the differences immediate release, enteric-coated, concentrations of medications, liquid medications, concentrations of suspensions. You know, pharmacy is a very specific profession. So I don't want to take up too much time, but I think it is somewhat of a concern, right? The language, dosage form. I don't know if we need to adjust it or not.
Board Member Doyle, we need to adjust this language to match the statute authority. But if there are members of the public who wish to change the statute in the future, then board rule could be amended secondary to that. Board Member Chin. Member Hall.
No comment.
Board Member. Oh, all right, this is a typo on the Board Member Joyce.
No additional comment. It's just, yeah, no additional comments.
Member Patel.
Patel, so. We already have statute, right? That technician can do final verification. Yes, we have to match language, but. Somehow, like, it should be like each pharmacist may delegate final verification of drug, device. Or product, like. Yeah, if you and drug dosage or delete the form or keep the dosage, I feel like it's going to be more confusing. Or we can say, yeah, verification of drug, device, or final product. Certified organ pharmacy, but that's just. Thank you.
Any other comments? Believe I've called on everybody once. Hearing none, is there a motion to move and send proposed rule OAR 855-115-0130 to the May 22nd, 2024 rulemaking hearing?
So move, board member Chen.
Is there a second? Seconded, board member Joyce. A motion has been moved by board member Chin, seconded by board member Joyce. And now call roll. Board President Doyle, yes. Board Vice President Chin,
Yes.
board member Beeman, board member DeBarnwell,
Yes.
member Hall,
Yes.
member Hemmons,
Yes.
board member Joyce,
Yes,
member Patel.
Patel. Yes.
Motion carries and, the proposed rule will be sent to May rulemaking hearing. We would now, move backwards to, mailing C4, Charlie 4, with staff member Davis.
Member Davis. This is an old rule, so Division 20. This is the board's first review of this rule of repeal. The rule was amended in December 2023 with an effective date of February 1st, 2024. That was to allow the vaccine protocols to come into effect. The effective date of February 1st, 2024 prevented it from being included in the broader repeal of Division 20 rules that were noticed in December 2023 for January 2024 rulemaking hearing. We already adopted a new rule, OAR 855-115-0345, Pharmacist Services Prescribing Compendium, which supersedes this rule and took effect on March 1st, 2024. To avoid conflicts with the new rule and meet the legal requirements for public notice and rulemaking, the board temporarily suspended this rule on February 29th, 2024. We have a rule that's temporarily suspended, but we need to actually go through the rulemaking process now to fully repeal it. So today's board meeting, the board will consider sending a permanent rule repeal to the May 2024 rulemaking hearing to potentially adopt in June to be permanently effective upon filing. Back to you, President Doyle.
Use, board member Doyle speaking. And we'll begin comments and, questions with board member DeBarnwell,
No comment.
member Hall,
Comment. No comment.
member Doyle, no issues. Board member Chin,
No issues.
member Joyce,
no issues?
member Patel,
Patel, no comment.
member Hemmons.
No issues.
Is there a motion to move? Send. Rule. AR 855-020-03004 repeal to the May 22nd, 2024 rulemaking hearing. For a second,
Again, board member Chin.
motion has been moved by board member Beeman, seconded by board member Chin. Call roll. Board President Doyle, yes. Board President, Board Vice President Chin,
Yes.
member Beeman, board member DeBarmore,
Yes.
member Hall,
That's,
Board Member Evans,
that's,
Board Member Joyce,
Yes.
Board Member Patel.
Patel, yes.
The motion passes and this rule will be sent for consideration. Further consideration of repeal at the May 2024 rulemaking hearing. Going to pause for one moment before I get indication from Staff Member Davis.
This is Staff Member Davis. I'm having a technological issue. I asked for just a minute or two to resolve that.
you're gonna look into this.
Next on the agenda, we are expecting to talk about mailing C1, that's Charlie 1.
I did that. Member Donna, since we're still being recorded in public session, may I ask a question about the operationalizing of that final verification that board member DeBarmore had brought up about there might be instances where there are patient safety concerns.
Just one moment. Staff member, Council Hunt, because we had stopped conversation on that package and already voted to send it to rulemaking period. May we continue to discuss a question regarding that at this time? Becky, please go ahead.
Thank you. So I'm just, not being a pharmacist person. We want pharmacists to be independent and use their judgment and rationale and be professionals, correct? So this is allowing that. We had this conversation, hopefully licensees are listening to what our concerns might be, but should there be an opportunity or is there a reason to say, if you're not utilized, in a information thing, if you're not utilizing these things, you might really think twice, or you might think hard about using your professional judgment to allow. I don't know, I'm just thinking in terms of safety, is there a way, how do you?
Board Member DeBarmore, I'll ask Board Member Beeman, because like from a retail perspective, how could you not use professional judgment without having a secondary way to verify what that product is?
And I think that's what final verification is in its simplest form, and what the legislature did with that statute is go the process of final verification, which if you asked a pharmacist doing it would involve several more steps to it and judgment involved. It's minimized because the act that they have defined as final verification is, well, it's comparing in most places, I would assume today in pharmacies, but I want to make that assumption because technology is varies depending on where you're practicing, but that you're comparing the image of said drug to what is in the bottle. And so sometimes we see this in when you put it a statute and the language isn't ideal. Inherently, what they're asking technicians to do in this is potentially could cause, if they only looked at drug and drug dose, and didn't actually in terms of applicability, but compare fill in the bottle to fill on the screen. Could potentially looking at drug and drug dose alone dispense the wrong medication, and board member Joyce highlighted that specifically with his fluoxetine example, because there are drugs that have two different dosage forms. So by the statute not including dosage form, that could be a workaround or a excuse of, well, I let it through because I was looking at drug dose and drug. However, in how you would actually do it, you would compare a picture to what's in the bottle or an NDC to, but even with an NDC number, you can compare it to what's on the label, but that could be an error. So it's typically a visual image, like a stock photo that you would look at the imprint and the color and all those different things. And then historically, as part of the labeling, there's a description of the pill on the bottle, so you would compare that as well.
Just board member Chin, my comment would be asking board executive director, staff, when we're talking about doing legislative things, and the legislature has mandated without our input, something that is a potential big patient safety issue in certain situations that don't have this technology or use this technology. Is this an opportunity for our board to do something in a legislative process to amend that statute to make it safe for Oregonians? That would be my big question.
Before Vice President Shin, would say that if it is the will of the board, to see any legislation change, it would need to go through the same process, that we did yesterday, where you gave me authority with the LC development process. Now that we're getting ready for 2025 long session and the budget development process has already kicked off, any legislation from the board would need to be within that process, which we would then need to provide within 2 weeks to the governor's office and the CFO's office within the budget process.
This is board member DeBarmore, that ideally in the outreaches and the relationships that are being developed, redeveloped, reinitiated, that ideally we would have an opportunity to have conversations with stakeholders putting forth language of this nature to make sure that this language is meets the intent of that. So there's not a gap, right? Or really hard to get legislation through. It's not an easy task. And then in the end to find can't be implemented because just somebody missed a different sentence somewhere else that prohibits what you just did and it can't be overridden, right? Or you don't have something worded just right, and poses a potential safety hazard. Ideally, it would be great if we have in the future better relationships where we have an opportunity to provide some input. I know we haven't been allowed to have, or haven't been allowed to provide, been silent or, not support or whatever in the past. It's been pretty, just be quiet and this is what we do. When those things come up, it would be really great if we have an opportunity to intervene before there are unintended consequences.
Actually, Director Fox, if I may, yes, definitely agree that there's opportunity to intervene and those opportunities, depending on when potential technical fixes are found. If they're found after session, then they would need to go through the legislative concept process that we're doing now. If they're found during session, there's an opportunity for agency staff and I to submit letters to the healthcare committees on both sides, the House and the Senate, and engage from that standpoint. And then also make sure that we're engaging with the legislative directors within DAS and the governor's office to make sure that we're all on the same page. And moving forward to alert them to whatever technical fixes there may be. But we are re-strengthening those relationships. So hopefully it's more organic as we move forward, particularly into the long session.
Stakeholders not having to go through legislators to make those fixes. It would be great if those relationships were with the stakeholders.
Believe that there are technical issues are fixed. I acknowledge that there are other hands that are up. But I would like to get back on track with our rulemaking hearing. And we have matters to discuss by the board. And I ask those board members who still have comments on this to raise those during that section of the board meeting, which will happen hopefully a little bit later today. Staff Member Davis.
Staff Member Davis, thank you for your patience while my computer decided to completely die. Okay, so we are going to be on mailing C1. This is on pharmacist services, prescribing, formulary, and protocol compendia. This is the board's first review of proposed rule language for the revision of rules in the formulary and protocol compendia. And the formulary rule, which is the -340 rule, it proposes to add continuous glucose monitors and related supplies to the formulary compendium. And in -0345, which is the protocol rule, it proposes to repeal the pseudoephedrine protocol from the compendium. It proposes to amend the tobacco cessation, travel medications, and a multitude of vaccine protocols within the protocol compendium. And it proposes to add a new sexually transmitted infections post-exposure prophylaxis protocol and short-acting opioid antagonist protocol to the protocol compendium. So there's a lot of moving pieces. We'll go through each of them. Today, the board will consider sending the proposed rules to the May 2024 rulemaking hearing to potentially adopt in June 2024 to be effective upon filing. The first rule is 855-115-0340. This is the formulary compendium. It adds that pharmacists may prescribe according to OAR 855-115-0330 and 0335, an FDA-approved drug and device listed in the following compendium, and adds to the compendium continuous glucose monitors and associated supplies. Utilizing the PFAX feedback form on the board website, a licensed pharmacist requested the addition of CGMs and associated supplies to the formulary. In February 2024, the PFAC discussed this idea and motioned to recommend it to the board, the addition of CGMs and related supplies to the formulary list. Back to you, Board President Doyle, for any discussion on the modification to this rule.
Board Member Doyle, we are speaking about C1.
C1.
The complete,
C1A.
the complete package of C1.
No,
No,
just-
C1A.
C1A, sorry.
So discussion on C1A, Board Member Hall.
Member Hall has no comment.
Board Member Dean.
Comment.
Board Member Doyle. With C1A, language and also how C1A presents it, and how uh, the contents of C1A present themselves within C1 as well. My question is it the most effective way to present things in what I believe to be chronological order as approval? Or, for example, I see that continuous glucose monitoring supplies is adjacent or similar thinking of diabetic blood sugar testing supplies. And is it better to group like things together in the list?
That's board decision. We just usually add it to the end of the list. We haven't been going back and re-lettering and numbering everything as we add.
And so I may be N1 in this matter if there are other board members that are interested in perhaps aligning things differently for readability to the rural readers, then please let that be known. Board Member Chin.
Member Chen, I am in comment in regards to adding CGMs. And right now the list isn't long enough that I think we need to, I'm not using the list, but it's pretty worth. And I think that most pharmacists, once they know which ones they are, it's in your head, you don't go back and look at the list.
Member Joyce.
Board Member Joyce, no, the list is fine to me. Yeah, there's some specificity in it, and I do appreciate this expansion of health access.
Member Patel.
Remember,
Member Evans.
Member
Member DeBarmore.
DeBarmore, I don't have anything to add. I would, on the protocol document, if they were in alphabetical order, or is that it just doesn't flow well? I understand you wanting to group them by kind of like themes. I can understand. I don't necessarily see going back and numbering the rule, but on the protocol document, does it have to be in the same order as the rule?
I don't see why it couldn't be in a different order. We just usually do copy paste.
Sure, understood, but because it was bulleted on the protocol document is why I was thinking less work. A strong feelings or another.
Board Member Doyle, in reference to that comment, I was just thinking about rural readers and is there any way if adding the newest to the bottom of the list is okay with everybody? You know, that is a known process that we're following. But if there is a better way to operationalize that in the future, then we could consider that. Any other comments from board members? Hearing none, I send it back to Staff Member Davis.
Staff Member Davis, so I have prepared my notes to say no in the order in which the protocols show up in the rule, not in the order in which the protocols were attached to the packet. So I'll be sure to call out the package letter so that you're aware of which one we're talking about. So we're going to move to OAR 855-115-0345, which is the prescribing and protocol compendium. And the first rule we're going to discuss within that package that's listed first is pseudoephedrine, which is a repeal, and it's C1C for the mailing. And the mailing just shows it struck through. By agency staff, so currently in the rule, the pharmacist can prescribe according to a protocol pseudoephedrine Agency staff recently became aware of a few statutes in ORS 475 that prohibit a pharmacist from prescribing a controlled substance, including a state-scheduled controlled substance, which is Sudafed. As such, this protocol is no longer permitted and must be repealed. ORS 475005, paren 6, and staff member Melvin is going to be putting these up on the screen so you can see them, defines the controlled substance as a drug or its immediate precursor classified in schedules 1 through 5 under the Federal Controlled Substances Act, 21 USC 811 to 812, as modified under ORS 475035. Pursuant to ORS 475035, pseudoephedrine was first scheduled in Oregon as a Schedule 3 controlled substance in 2006. As you may remember, because this was more recent, it was changed to a Schedule 5 controlled substance in 2022. ORS 475973 prohibits the Board of Pharmacy from adopting rules that exempt a product that contains pseudoephedrine from classification as a controlled substance. We can't make it a non-controlled. It has to stay controlled. We moved it from a 3 to a 5, and that's where we are, and that's where we have to stay for now. ORS 475005, paren 17, defines a practitioner as a physician, dentist, veterinarian, scientific investigator, licensed nurse practitioner, physician assistant, or other licensed person licensed, registered, or otherwise permitted by law to dispense, conduct research with respect to, or administer a controlled substance in the course of professional practice or research in this state, but does not include a pharmacist or pharmacy. Then finally, in ORS 475185, it prohibits a controlled substance in Schedule 5, which is in paren 3, I think. Schedule 5 from being dispensed without a written, oral, or electronically transmitted prescription of a practitioner. Just went over the definition of a practitioner that does not include a pharmacist. Because a practitioner cannot be a pharmacist, a prescription cannot be prescribed as for pseudoephedrine as a Schedule 5 drug by a pharmacist. While removing the protocol from this compendium may decrease access, there was a large expansion of access that occurred with 2022 House Bill 4034, which permits licensees to sell or transfer pseudoephedrine from behind the counter in alignment with federal limits. Nothing prohibits a practitioner as defined in ORS 475005 to write a prescription that the pharmacy may then fill and dispense. Back to you, President Doyle, for discussion on repeal of the pseudoephedrine protocol.
Member Doyle, thank you. We're talking about package Charlie 1, Charlie C1C. Comments or questions for Board Member Stephen? Board Member Doyle, nothing for me. Board Member Chen,
Comments?
Member Joyce,
Issues?
Member Patel.
Member Patel. I just don't get it. I don't get it. So we have statute. Board members have authority to promulgate the rules. To promulgate the rules, we have the pseudoephedrine protocol since 2021, working great. None of the statute or anything changed. None of the public or licensee challenges make any change. And matter of fact, the previous rulemaking too for the final delegation of the final verification. And so pseudoephedrine too. So no one is challenging us, and why we are changing it? I mean, like, didn't we just pass the rule about that technician can do final product verification? We just passed it. No one challenges. They're changing it now. Pseudoephedrine working just great since 2021. No one challenged us that, hey, Board of Pharmacy or board members change that. But why we are changing it? I just don't get it. So no, I'm going to oppose that.
Reverend Hammond, do you have an answer for that question, why you changing it? Okay, just gonna ask the question. Reverend Hammond, so the reason why we're changing it is because we discovered that it was incorrect.
Staff member Davis, yes, we discovered that we have a statute that prohibits a pharmacist from prescribing controlled substances, which includes pseudoephedrine.
So we made an error by actually allowing pharmacists to be able to prescribe.
That is correct.
Now we're trying to correct that mistake because we discovered it.
Correct.
My next question was, how will this impact the public? So it's a Schedule 5. So it's kept behind the counter. Still don't need a prescription to get it. So what's changed? What's different? What's gonna be different if you repeal this?
Board Member Doyle, a patient will not be able to obtain a prescription from a pharmacist and therefore a barrier to getting the medication would be a lack of insurance coverage. So there may be an increased cost to a citizen, and also the amount of pseudoephedrine that a citizen may obtain at any one particular point in time could be different from what a prescription may be able to provide.
So, Board Member Hammond, so the impact would be patients who would prefer to get a prescription, to get it covered through the insurance, because the copay and the cost might be zero or less than what they would pay out of pocket without going through insurance.
Remember Doyle, that is correct. And also they still have an option of getting a pseudoephedrine prescription from a different prescriber than a pharmacist.
Board Member Hammond, how many people even knew they could have gotten a prescription from their pharmacist? I didn't know my pharmacist could prescribe anything.
Remember, this is voluntary.
Staff member Davis, participation in these protocols is voluntary by pharmacists. So even though we have the authority, not all pharmacists would have even done this service. I was not able to locate data that shows like how many pharmacists are prescribing, how many prescriptions are issued. I don't have that information. So there is a potential impact. I don't know how large or small the impact is.
Okay,
Maybe.
Board Member Hammond, so is there any penalties to the board because you have allowed pharmacists to violate the law all this time?
Council,
I mean, we're fixing it, moving forward, we're fixing it.
microphone, please.
I said, moving forward, we're fixing it, right? So we've become aware, knowledge of that.
So from this point on, if, once this goes through, any pharmacist who prescribes pseudo, whatever it's called again, would be in violation, and that could be a complaint that could come to the board. But prior to this, if we had received a complaint or anything, we would not have done anything because I said it was okay. Okay, thank you.
Whoever the board wants.
Board member. I don't, that makes sense. The legislation for the other circumstance is what brought our attention to this. It's an unfortunate circumstance. It's my previous conversation. Not have anything to happen. Unintended consequence of other action.
Member Hall,
Member Hall, no comment.
Member Beeman.
But Member Beeman, I have nothing to add.
Thank you. We've concluded discussion on C1C. Staff Member Davis.
Going to move on to tobacco cessation, which is C1D, is your mailing.
Member Hammond, sorry, so don't we vote on that? Other one?
Just send it.
Staff member Melvin.
Staff member Melvin, so after we review all of these protocols, then you guys will entertain a motion to send the rule to rulemaking to get comment.
Board Member Patel, I just want to make comment on the previous rule. Reason most of the pharmacists, they don't use the protocol because we are also barrier. You can pseudoephedrine, you can prescribe, now you don't. Final product verification, you can do it. Now we are going to change it again, right? The naloxone protocol saying you can do this, keep changing protocol too. Why pharmacists will take the liability if we are constantly keep changing everything? Right? That's the only reason. And no one challenged, nothing.
Member Doyle speaking, staff member Davis, the next package, please.
So for the tobacco cessation protocol, I'm just going to highlight the major changes to the protocol. You can see in the protocols, I've highlighted with like yellow bookends, like things where things have changed. So like you're going to see on all the protocols, a change in these rule numbers on the cover page, because that used to say Division 20 rule numbers, and now we've changed it to Division 115. But we're going to move to the patient intake form on this packet. The subject matter experts proposed to the PFAC, who then sent it to you for review to remove what was question 3. So you only see like, well, scroll down. I can't highlight something that's not there, but if you were to pull up the protocol on the website, you can see question 3. What it said was, are you currently using and trying to quit non-cigarette products? Example, chewing tobacco, vaping, e-cigarettes, or Juuls. This is being removed to allow pharmacists to prescribe for dual tobacco users or nicotine users, and have added the question to the top of the assessment. So they moved it out of paren 3 and now it's at the top. They also removed question 8 on the health and history screen. It used to say, do you have asthma or another chronic lung disorder? Example, COPD, emphysema, chronic bronchitis, as the NRT inhaler has been discontinued. So the question is no longer needed, as that question was being asked specific to the nicotine inhaler product. On the assessment and treatment care pathway, they removed step 2 as it was related to question 3 that we just removed. So you don't need that step if that question is not on the assessment and treatment care pathway. They updated the pharmacist guidance in step 5 to address dual users. They added information on nicotine replacement dosing to address dual users. They removed the nicotine inhaler from the nicotine replacement dosing. They extended the maximum duration of prescribing that can occur in the prescribing parameters to 24 weeks. If you scroll down, I don't know exactly where it's at. I can see it. This is the dual user stuff. Right here, prescribing parameters, they changed the maximum duration to 24 weeks. They clarified that follow-up should occur within 7 to 21 days after the patient starts tobacco cessation medications. They may have the consult, they may think about it for a while. We don't need to follow up with them until they've actually started the tobacco cessation medications. And then added an entire section on medication counseling points, just as an easy reference for pharmacists. There were no other changes to documents in this package. So while we still have to show you the whole package, it was only the patient intake form and assessment and treatment care pathway that had proposed modifications. Back to you, President Doyle, for any discussion on changes to the tobacco cessation protocol.
Member Doyle, thank you. Calling on. I begin the round robin. I do not have any questions on the tobacco cessation protocol. Board Member Chin,
Comment?
Member Joyce.
Laura and Joyce, Juul is a brand. I don't know if we need to capitalize it, but I mean, when you see it visually, in a computer or, out in the public or whatever, it's capitalized. I don't know if that makes a difference in this particular form or not, but
We'll make a note. Thank you.
Thanks. I don't want to promote it. That's. Dr. Patel.
Board Member Patel. Don't know if we discussed before or not, but still there is a pharmacist training and documentation and everything. I know there is no change there, but I don't know why we are making so complicated. Why can't we just do the standard of care, and why we have protocol to make like pharmacist job miserable? I'm going to oppose this.
Dr. Evans.
Number 10 is, so this is new to me. So a pharmacist can actually do tobacco cessation counseling and prescribe. I could send my patients to pharmacists to do it.
So there's a whole list of things that pharmacists can do through the protocol compendium, so.
Some patients who need
Pharmacists volunteers to go.
Oh, okay.
Volunteer.
Yeah, but I didn't know that. So this is great. Awesome. Thank you.
Board Member Barmore,
Second.
Board Member Hall,
Member Hall, no comment?
Member Beeman.
Beeman, nothing.
Well, actually, in regards to Member Joyce's comment, I did wonder why we're calling out one specific brand. And I don't know the technology behind these, so forgive me if I'm ignorant on
This
this.
is Juul a vaping.
I thought it was a vaping device, but I don't know if it has some sort of a different
There's a
name or
brand.
something, but it,
One at a time, please.
remember being, but we're saying everything else in terms of the tobacco technology, for lack of a better term, and then calling out one brand, which is kind of odd to me, so just.
Staff Member Davis.
Staff Member Davis, I'm not the subject matter expert that wrote this. My understanding just from conversation, they already mentioned vaping. I think in the world, a lot of people just refer to Juuls, or it's like a slang term. And that they wanted to make sure that patients understood that they were talking about that particular type of thing. Patients don't walk around calling it vaping, apparently. And Board Member Hemming seems to be nodding in agreement of that statement.
Or Joyce, yeah, I guess it would be the equivalent of certain parts of the country, like in the South, they call everything a Coke, even though they mean a different soda.
Hold on.
What kind of Coke do you want?
We concluded the discussion on tobacco cessation, and Staff Member Davis, please identify what we'll be talking about next.
Staff Member Davis, we're gonna go back because I accidentally skipped continuation of therapy, which was C1B. So we're gonna go back and just grab that one real quick.
Which, look, here's, I'm gonna pull it up for you. Which one is that?
C1B.
I know, but I'm
Oh,
giving
you
you a
don't
word
have
because
to.
you want to edit something. I thought you
It's
said-
just, no, I don't need it.
Oh, okay. Yeah, hang on.
There's only one change to this protocol, and it's on the cover page.
Hang on, I'm sure. What you were trying.
Staff Member Davis, C1B. The change to this protocol came from, again, a licensed pharmacist within the state submitted a feedback form and asked for clarification on what does damaged prescription drug or device or drug mean. And so the committee discussed it in September. They drafted some language. We came back, they discussed it further in February, and this was kind of the language they decided upon. So you see the rule number change in the first line following all the elements. And then for consistency, I think it had said prescribed damaged medication. And so they wanted to change it to drug or device so that it's clear that it's not just a medication, it's a damaged drug or device. And then they gave kind of a definition of a damaged prescription drug or device. The pharmacist must use their reasonable professional judgment as defined in our rule to determine if the drug or device is damaged. This includes physical damage like broken containers or spills, chemical changes like discoloration or unusual odors, and damage from exposure to heat or moisture, which can affect the medication's effectiveness and safety. So this was just being done, this modification, as a result of feedback that was received from a pharmacist utilizing the protocol. Back to you, Board President Doyle.
Member Doyle, around the table, discussion for continuation of therapy. Board Member Chin, any questions or comments?
Just a comment, when you added, drugs and device, you didn't continue that. You can damage a device with heat or moisture and affect the effectiveness and safety, and you only put medications in.
Okay, we can fix that.
You make it an
Otherwise, it's good.
Member Joyce,
Board Member Joyce, no comment.
Member Patel,
Patel, no comment.
Member Evans,
No comment.
Right. So it's
Barb,
what to do.
Nothing to add.
Member Hall,
Comment,
Member Beeman,
no comment.
Member Doyle, nothing additional. We concluded a conversation on continuation of therapy and we move to the next package for direction of Staff Member Davis.
We're next going to cover travel medications. This is C1E. This is modification to a current protocol. So again, the subject matter experts brought a number of changes to the committee. You'll also see these reflected in some of the vaccine protocols because there was a major update. So for travel medications on the cover page, updated rule references, you will notice that throughout the protocol, they have changed the term acute mountain sickness to altitude illness prophylaxis, which is consistent with the current terminology used within the travel medication world. They have also updated the resources to the recently published 2024 Yellow Book. So we were previously relying on the 2020 Yellow Book, and the 2024 version has a number of updates. And so that's, again, what you'll see throughout this protocol. The next changes are on the patient intake form. They removed a duplicative question about allergies that was in the demographics section. So it was up top and then it was further down. They've just removed it so it's not listed twice. They have updated question 5 concerning altitude to be consistent with the Yellow Book. Again, the terminology, all the things around altitude illness have changed. They also added additional vaccines to the vaccine table that the patient could provide information on, recognizing that some patients are from countries that have vaccines for these products. We do not yet, although we are in the process of obtaining some vaccines for like something like chikungunya was just approved. On the assessment and treatment care pathway, they clarified language related to entering and exiting from the malaria risk area throughout the protocol. So if you scroll down, like every single time, they change from entering the malaria risk area to exiting the malaria risk area. It said inconsistent things like entering the malarious area, entering the area where you could obtain malaria, so they just made it consistent throughout. They've adjusted all the treatment regimens to align with the 2024 Yellow Book. They've changed, again, the acute mountain sickness to altitude illness prophylaxis. And under contraindications, they added a hypersensitivity to acetazolamide and cross sensitivity between acetazolamide, sulfonamides, and other sulfonamide derivatives, since acetazolamide has a sulfa component. That's all the changes to the assessment care pathway. And then on the provider facts, they simply made a small change of changing the word immunizations to vaccines to be consistent with that we have vaccine protocols now instead of immunizations. So just see these altitude sickness changes, immunizations change to vaccines, pretty minor changes throughout. Back to you, Board President Doyle, for further discussion.
Member Doyle, we began conversation with Board Member Chin. Correct?
Like the first last time.
I did. So,
Then I have no comment.
Board Member Joyce,
Board Member Joyce, no comment.
Member Patel,
Board Member Patel, I don't have comment on whatever you proposed, but I have a quick question though. It would be nice, because I searched for it and there is a 4-hour comprehensive training program related to pharmacy-based trial medicine. I hope like if we can add the link, like where to find and everything, it's sometimes hard to find, so. That's just the one comment. Then so do for the 1-hour travel medicine CE. I didn't see in the pharmacist later, but I may be wrong. But the 4-hour one, it would be nice to have some link where to find those trainings.
Board Member Kevin, how is this similar to the, are you able to find a pharmacist who will prescribe travel medications pretty easily in the state of Oregon? Or it's just you? They don't count.
Member Davis?
In like a retail pharmacist, is it pretty easy that most pharmacists in the state of Oregon would prescribe travel medications?
Member Patel?
Remember, Patel, I was planning to do it. But then it's hard to find training.
You have to be.
Yeah, you have to do training and then there's other requirement. It's just because of that training is component barrier. But no, if I don't have like for scopolamine patch, right, there is like, you have to do training. And I was like, what possible training do you need for scopolamine patch? You just put on the, they just side effect, right? So the things like that is like barrier, but in this protocol, but it is easy if you remove those barriers. Yes, we can do instead of the public, they have to go to urgent care or primary care provider, special. Yeah, and then we have the fisherman community, right? So it'll be easy to hop in pharmacy get it than spending like $200. So, yeah.
So, Board Member Hammond, is that in this protocol? Does it say that you have to have 4 hours training somewhere?
You have to have, it says right here, pharmacist trained
Okay,
education.
great. Thank you.
Yeah.
No comment.
Staff Member Davis, I did want to address that I know of 2 major chains that have done extensive training for their pharmacists to be able to utilize this protocol. I don't know how much it is utilized, especially post-COVID, but I am aware of colleagues and friends that work in chain retail that are utilizing this protocol.
Member Barmore? Member Hall?
All no comment.
Think I,
Board Member Doyle, I just have a friendly amendment, on page 2, which is the self-screening, patient intake form, as you had pointed out. Addition of altitude specificities. I noticed that either the question mark is in the wrong place after altitudes, or in the mountains might have been something that had been meant to be stricken.
I'll go back and review the minutes from that meeting, make sure.
Staff Member Davis, you have the floor.
We're going to be moving on to new protocols. So we've been talking about protocols that were already in existence. Now we're going to talk about 2 new protocols. The first one is for sexually transmitted infections, post-exposure prophylaxis, also known as STI PEP. This is mailing C1F as in Frank. The board received a concept submission in the fall of 2023. A full protocol package was then received from a licensed pharmacist who has served as the subject matter expert, and we received that in January 2024. At the PFAX February 2024 meeting, they motioned to recommend this protocol to the board. The STI PEP protocol package consists of 6 parts: a cover page, patient intake form, assessment and treatment care pathway, prescription template, provider fax, and patient information handout. All the documents in this package are required except for the prescription template. Doxycycline post-exposure prophylaxis, also known as DoxyPEP, means taking the antibiotic doxycycline after sex to prevent getting a sexually transmitted infection. Studies have shown that taking DoxyPEP reduces the chance of contracting syphilis and chlamydia by about 2/3, especially if you're a transgender woman or a man who has sex with men. On October 2nd, 2023, the U.S. Centers for Disease Control and Prevention, or the CDC, issued proposed guidelines for using the antibiotic doxycycline as post-exposure prophylaxis to prevent these bacterial sexually transmitted infections. The patient takes 200 milligrams of doxycycline as soon as possible within 72 hours after condomless oral, anal, or vaginal sex, and the maximum is 200 milligrams per every 24 hours. So for this protocol, I'm just going to point out the things that are maybe a little different and kind of walk you through it. It's brand new. There's no required training, but there were 3 programs that were provided as potential recommendations for where you could get your training. On the intake form, it utilizes the standard demographic information at the top, and then it has 12 questions to assist the pharmacist in determining if STI PEP therapy is indicated. The pharmacist then uses the patient's response to those questions and looks at the assessment and treatment care pathway. So in step 1, they review the patient's population eligibility for enrollment in the protocol. The patient must be at least 13 years old, must identify as gay, bisexual, or a man who has sex with men, or a transgender woman who has sex with men. In step 2, the risk assessment algorithm has exceptions for treatment failures, current STI symptoms, condomless sexual contact. It also includes a recommendation for bacterial STI testing before initiation. However, that is not required in order to participate in the protocol. Step 3 is a therapy assessment. So if there need to be referrals for sexual assault, they may need HIV, PEP, or PrEP, and also discussion on risk reduction. Step 4 includes medication and disease state screening, so looking at contraindications and precautions for the use of doxycycline. Step 5 is assess and initiate therapy. Step 6 is completing the patient encounter, counseling on the medication and risk reduction. And step 7 is parameters to continue therapy beyond initial prescribing. The next page is the prescription template, which is optional. The following page is the provider notification, which provides them with information on the lab testing results if they are available, and provider pearls on the prescription that the pharmacist has issued. And then the last page is a patient handout on Doxy PEP, STI PEP, and what they need to know. Back to you, Board President Doyle, for any discussion on this protocol.
We begin discussion on STI PrEP with Board Member Joyce.
Board Member Joyce, no, this is very good. We're expanding healthcare access to groups that are historically been marginalized. And I appreciate this expansion of healthcare access. As far as the protocol itself, I mean, it looks good at first glance. Thank you.
Member Patel.
Remember Patel, no, looking good, and that's what I want to see. That pharmacist training and education, not required, recommended for every protocol. Move the barrier. Thank you.
Member Emmons.
Board Member Evans, so your pharmacist, 13-year-old comes in and makes a request. You would do what?
Would have them fill
Or
out
something here,
the patient intake form.
13 years old.
Correct.
Um,
And assess their answers according to the treatment care pathway and make appropriate referrals if necessary. The situation.
12-year-old comes in. What would you do? Nothing? Wouldn't even. Or, I mean, any person under the age of consent comes in with this request but should be considered the non-consensual sex. And as a pharmacist, you are a mandated reporter. So what do you do first? Do you treat, then report, or report and not treat? Let's say the person's 15. The 15 you can prescribe. So do you report, not treat, or treat and report?
I'm not the subject matter expert on this. I did not create this protocol. My understanding is that 13 years was chosen because that is the age the CDC provided guidance to utilize this medication.
I'm talking about the age of consent within the state when it's consensual sex. Under 17 is not.
So are you
What's in
proposing?
this protocol that directs the pharmacist to let them know? Says they are mandated reported. I saw that somewhere. Where does that factor in? The role of the pharmacist, if you have a 15 or 14-year-old that comes in, makes this request.
Board Member Doyle, the age of 13 also, it doesn't directly answer your question, but the age of 13 is also the limit for the HIV PEP and PrEP protocol.
I have the same question here. Too.
Yeah, so, but, so this protocol is aligned with those two others that are already in force, if you will, in Oregon. But with regard to mandatory reporting, I'm not able to answer your question. And I don't know that that needs to be part of the protocol because it's should otherwise be known by the practitioners for the mandatory reporting.
Could we scroll to where you have that, where it says something about mandatory reportings?
Medication
Was it in
assessment.
the protocol?
Go back up.
In the footer.
We're looking. What I'm hearing you say, and I think is a very valid
That's a
and
social work.
a good
Perfect.
point. I wasn't intending to do that, but is that we should maybe go back and look at, because I was also thinking contraception, we also allow 13 and over. There is no age limit. So maybe to just reassess and look at the state laws and if all the protocols need to be updated with some sort of language consistent for minors that are participating in sexual activities.
Remember,
Contraception is a bit different, but this, yeah.
I'm sorry.
on page 4 under para 3, comprehensive therapy assessment, it's with regard to the patient answering question 8, sexual assault victim or survival. That's where it indicates that Oregon pharmacists are mandatory reporters.
I wanted to see where, because I saw it somewhere here, it talked about that pharmacists are mandatory reporters. I just wanted to see where,
I was explaining on page 4.
We don't have page numbers. Can you give me a letter and a number, please?
Para 3,
Back up.
of the standardized assessment and
That's-
treatment
yeah,
care pattern.
Thank you.
Okay.
So the answer,
So this is where your problem is, right? Because you're using the terminology sexual assault, which I think for some pharmacists may not equate that to child abuse. Right? But yeah, I agree. I think it's something to look at in terms of the state and guidance there. I don't know, as Board President Doyle said, we're not going to go in the protocol, but be something that's addressed.
Board Member Doyle, yeah, this is also the same language that you used in the HIV PEP and PrEP protocol. So a overall view, I think is warranted for future protocols to make sure that we're helping pharmacists keep their mandatory reporting obligations. Any more comments, Board Member Evans?
Yeah, because, in this situation, a pharmacist could be that person, right, to identify and, allow that individual minor to get help.
For DeBarmore?
Board Member DeBarnwell, I don't have anything to add.
Member Hall?
We're all nothing to add.
Member Beeman?
Remember, maybe nothing to add.
Board Member Doyle, nothing to add. Board Member Chin?
Yeah.
Any other, further comments with regard to this protocol? Seeing and hearing none, Staff Member Davis?
Staff Member Davis, we're going to move to short-acting opioid antagonist mailing C1G. The board recruited subject matter experts in the spring of 2023 to assist in the creation of this protocol. While pharmacists have the independent authority to prescribe these medications per ORS 689-802, experience has informed us that pharmacists like having pre-made protocols and documents to utilize. Thus, this group of subject matter experts have created a protocol package for short-acting opioid antagonists in the fall of 2023. At February 2024 meeting, the PFAC motioned to recommend this protocol to the board. The protocol package consists of 6 parts, similar to the last one: a cover page, patient intake form, assessment and treatment care pathway, prescription template, provider facts, and patient information handouts. All documents in this package are optional, except for the assessment and treatment care pathway. So we'll pull it up, the cover page, no required training, but many resources. There's also no limitation on the quantity supplied or the refills that are provided to the patient. On the intake form, most demographics are optional. We just need the name of the requester. If you're utilizing that form, a simple little question: do you want a kit, and how many doses do you want? So really 2 questions in one. On the assessment and treatment care pathway, if the patient wants a kit, we can prescribe based on patient preference or professional discretion. You can prescribe any available short-acting opioid antagonist, nasal sprays, injectable, and there's a list of prescribing considerations included. There's also patient counseling tips, and it does remind pharmacists about the labeling exemption that's in ORS 689-813 for nasal sprays that are personally dispensed by the pharmacist. The prescription template's optional, the provider notification is optional, and then the patient handout is a copy of OHA's written training for administration of what was originally naloxone nasal spray and injectable. They have not updated this training that's available on their website to include products, but it gives the general idea of doing a nasal spray or injectable. Back to you, Board President Doyle, for any more discussion.
Can we begin, board discussion with Board Member Tell?
Remember Patel. Question to board consult, you said pharmacist love protocol, that's what we create one?
Experience has informed us that pharmacists do appreciate having the protocols and the documents, and they utilize those. And so we're just trying to make one step easier so they don't have to create their own, or we'll wait for their company to create a document or form. They don't have to utilize this. They can still prescribe on their own authority. They can choose to prescribe this way. They can also prescribe via, not they prescribe, but they can also utilize the statewide standing order that's been issued by the medical director in the state. They can have that.
You can use
Any or all.
statewide.
Okay. Sorry, there's a new statewide protocol that was issued by our state medical director that pharmacists can utilize. It's essentially a prescription written in advance, and it's you put the patient's name at the top. You can scan it as your hard copy, use that physician's name as the prescriber. It's on our website under our short acting antagonist web page. There's information coming out about it in our May newsletter, so it'll be going out to pharmacies. It limits it only to naloxone products and 2 of the products. So it's not all encompassing, but what it will do is provide pharmacists who maybe aren't registered with OHA as a provider and network. That medical director is an in-network medical provider, and so it will create an additional pathway for patients to be able to receive naloxone if they have the Oregon Health Plan or a CCN.
Member Patel?
Thank you for clarification. So pharmacists can use this protocol, use OHA protocol, or they don't have to use the protocol. It's over the counter. So thank you. No comments.
Member Evans?
Board member Hammond,
Member DeBarmore?
board member DeBarmore. Comments.
Member Hall?
Member Hall. The only thing I was gonna say, sorry. Was to I don't know if we want to include resources or additional points, like on page, like on pages. Counseling points. Addressing concerns and answering questions, and then additional points. How bringing resources for groups and crisis hotlines and whatnot. And I just didn't know if maybe it's ever changing and not something you would want in there, but
Board Member Hall, that's a comment for the future contemplation of the Pharmacy Formulary Committee. You'll have a specific change that you'd like to see at this time.
changes.
Review.
Board member Bean,
Board Member Doyle, no questions. Board Member Chin,
No questions.
Board Member Joyce.
Board member Joyce, yeah, expanding access, with short acting, opioid antagonists, it's all good. Thank you.
One question.
Board Member Patel.
So my question is like, so why can't we put on the formulary? Then it will be standard of care.
Great question, Staff Member Davis. I actually really wanted to do that. The law that permits the formulary requires a diagnosis. And we wouldn't have a diagnosis from a healthcare practitioner that's qualified and authorized to issue a medical diagnosis in order to prescribe naloxone. So if the formulary did not require a diagnosis, then this would be something that would make total sense to put on the formulary. But because we don't have a diagnosis, we can't put it on the formulary.
Then it's over the counter. Naloxone is over the counter, right? Like I see one in our restroom.
Correct, it is over the counter, but that doesn't have anything to do with the formulary. You have to have a diagnosis in order to prescribe off the formulary. It has to be documented.
Which that's not my understanding, but I think I'll come up with more facts. I don't know. I think I sort of disagree.
Gone around the table for comments on C1G. We will conclude that and move to the next package per Staff Member Davis.
Staff Member Davis, we're going to dive into the vaccines. These are mostly minor changes, so we should be able to cover quite a number of them. I'm not going to come back to you, Board President Doyle, until I just go through all of them. So we're going to kind of go in rapid succession. So if you have any comments or questions, please just make a note, and at the end we'll ask you if you have any protocols you want me to pull back up for review. So for the protocols, there are 2 standard protocols for all vaccines. Rather than repeating this information at the front of every protocol and making it extremely long, the subject matter experts had recommended the 2 protocols stand alone and then be used in conjunction with the vaccine-specific protocols. The SMEs, of course, built all these protocols off of the protocols that were previously published by the OHA. And then now we're in the process of maintaining and updating as ACIP changes occur, or package insert or new products exist and different things like that. So for paren A, the standard protocol for all vaccines, which is mailing C1H. The only thing that changed in this was updated rule numbers and the reference to the yellow book being changed to the 2024 yellow book. So just a reference and rule number change. Paren B in the rules, standard protocol for all vaccines managing adverse reactions, that is C1I. Updated rule numbers, and then also added a requirement, and it's on the very last page of this one. So I want you to be, no. Yeah, there, that. They also added a requirement to have a regular adult and a large adult blood pressure cuff per the suggestion of a licensed pharmacist. So we got a feedback form that said, hey, you require a pediatric cuff if you're giving it to peds, but what about your adult patients that maybe need a large cuff? The committee reviewed that and made the recommendation to the board that a regular and a large adult cuff be required in the pharmacy. If you're giving vaccines to adults, if you're only giving it to pediatrics, you could just have a pediatric cuff. The next protocol is the coronavirus 2019 protocol. Coronavirus and 2019. It is paren D in the rule and C1J in the mailing. The board has already adopted this protocol as a temporary rule. You may remember that special board meeting we had in March. There are no further changes to this. This is the same thing you've already adopted as a temporary rule. It is just to go through the permanent rulemaking process now. Paren E in the rule and paren C or C1K in the mailing, Haemophilus influenza type B. The only thing that has changed on that protocol is that they removed the latex allergy from the 2 formulations. So you'll see that in the what's new at the top. And then when you scroll down somewhere, there's components to the vaccines and they have removed the latex allergy. I think it's been removed, so you can't see it on the protocol.
Yeah.
Hard to show you what's not there. In paren I in the rule and C1L in the mailing, influenza, inactivated influenza vaccines and recombinant influenza vaccines. They went through and did a pretty decent cleanup based on feedback that we had received via feedback forms. Feedback forms, as you can tell, we're getting a good frequency of them, and they're very helpful because they're the pharmacists that are using these protocols saying, I have a question. Can you please clarify this? So they had pharmacists had asked to clarify the dosing based on age and product formulation. There was one product that the dosing is just different than the way that it usually is for children. And so they went through and kind of did a wholesale revision of the entire document to make sure that it's very clear what age it starts at, what age it goes up to, and then what the correct dosing volume is based on each product. They also added the amount of hemagglutinin for each vaccine to the table. So that it was a little clearer as to, I guess, why the volume is different so that the patient gets a different amount of the active virus. The next protocol is in paren K in the rule, Japanese encephalitis, and it is C1M in the mailing. All that has changed in here is an updated reference to the 2024 yellow book. So no clinical changes, nothing else, but just updating the reference to cite the correct 2024 yellow book. Paren L is meningococcal vaccines. This is mailing C1N. This vaccine, it has added Pembrya. It is a new vaccine that combines the MenACWY and the MenB into one vaccine. So it's not a new strain of meningococcal. We're not having to attack anything particularly new. It's just a new presentation. And so they went through and added all the language that was needed, the correct dosing, the dosing schedule, any contraindications, things like that. But it's not a new vaccine virus. It's just a new combination instead of having to be two separate vaccines. The next one is paren N pneumococcal, which is C10. They have gone through and removed the PCV 13 from the protocol entirely. That product is no longer on the market, and so it no longer needs to be on the protocol. They also updated all the tables to provide clarity on dosing and spacing, especially because, I mean, I thought it was confusing a few years ago if you were doing pneumococcal vaccine. Now it's, I think, even more confusing. So they really tried to put this into tables and charts to make it very clear as to what schedule and what doses. They also added clarification on the shared clinical decision-making requirements. As you may remember, that was one of the major reasons we were pulling these protocols into under the board's authority so that the pharmacist could engage in shared clinical decision-making, but the pharmacist is not allowed to use discretion or judgment. They have to follow the guidelines that are provided in the protocol. And so they clarified that section of the requirement for pneumococcal vaccine. And paren O for the polio vaccine, mailing C1P. They added routine recommendations for adults who are known or suspected to be unvaccinated or incompletely vaccinated. This was a change in ACIP to now have a general recommendation for polio vaccine. And then they've also added a recommendation for adults who are at increased risk for exposure to polio virus. So it went through, and you can see like now it has an age 7 through 17 years general recommendation. And paren Q, respiratory syncytial virus, mailing C1Q. It was clarification on the administration of Abrevisa, which is one of the products during the final trimester of pregnancy and future pregnancies. There's been a lot of data, studies, publishing going on, particular to this vaccine and pregnancy. And so they were updating the protocol to reflect the most recent data and recommendations. And paren R, tetanus, diphtheria containing vaccines. This is mailing C1R. They updated the recommendations concerning inadvertent administration of Tdap to 10-year-olds. This was a change in the ACIP recommendations. Once again, they used to say, I think it was used to have to repeat the dose, and now it can be counted towards the patient's dose that they would get from 11 to 12. So they went through and updated the protocol to reflect that. And then the final vaccine protocol is the yellow fever, paren U, and it is mailing C1S. And all that was done to this protocol is updating the yellow, the yellow book to the 2024 version. With that, I will stop my very quick Rolodex through the vaccine protocols and give it back to you, President Doyle, for any comments or questions from the board on the protocols.
Doyle. So now is the time for board members to ask questions or comments on items C1H through C1S, the standard protocol for on vaccines as well as the vaccines. We begin with board member Evans,
No comment.
member DeMarle,
Nothing.
member Hall.
Member Hall, I just had a quick question. No comments on everything, but on C1J for the coronavirus. It's just an asterisk that I don't see a reference to under side effects and adverse reactions, number 9. Goal.
Just keep going, it's way down.
7 for me.
That's page 7. It's numbers, section 9, right?
Section.
Speaking of the asterisks after lymphadenopathy,
Scroll down.
Oh, you passed it, sorry.
Yeah, no,
I was just trying to see if there was anything further down. I know that they updated all of those charts based on the updated information. I'm guessing that asterisks forgot to get removed when we did the update that happened in March. I'll go back and just double, triple check, but I'm like 99% confident that they had redone all the numbers, and I think they got removed whatever had been underneath, so we can remove the asterisk.
Thank you, that was it.
Member Stephen?
Even
Board Member Doyle, just a, quick notice that on the pneumococcal protocol C10, in a couple of the tables, it appears as if there is some artifact, that after that is stricken language that needs to be removed after the word complete on the next due column of the the table for persons with immunocompromising conditions as well as chronic conditions.
What page? We have the same page numbers for this.
So for example, at the bottom of page 3, there's a table for immunocompromising conditions.
Strikes right here.
Why would that's stricken?
That was the symbol.
Just really strike, I can't, let me pull this up a little.
Scroll down, scroll down. That's the
Oh,
symbol.
that's the symbol, okay.
Yeah.
Thank you for clarifying. As a reader for the first time, it looked to be artifact. So like track changes that did get corrected. Thank you. Board Member Chin,
No comment.
Member Joyce,
Or Joyce, no comment.
Member Patel.
Member Patel, no comments.
We'll make motions at this time, and just for clarity for everybody, it's anticipated that we'll be making a motion on 2 different rules. And all of the protocol packages are nested within. And so board members who are opposed to certain protocols may self-reflect on, see if they want to say no to the top level motion that we will be considering, and we'll evaluate the outcome thereafter. So is there a motion to move to send proposed rule OAR 855-115-0340 and OAR 855-115-0345 to the May 22nd, 2024 rulemaking hearing?
So move, Board Member Chin.
Seconded, Board Member Joyce.
The motion that's been made by Board Member Chin, seconded by Board Member Joyce. So I'll now call roll for a vote. Board President Doyle, yes. Board Vice President Chin.
Yes.
Board Member Beeman.
Yes.
Board Member DeBarmore.
Yes.
Board Member Hall.
Yes.
Board Member Hemmons.
Yes.
Board Member Joyce.
Yes.
Board Member Patel.
Member Patel opposed.
Motion passes with Board Member Patel opposed, and those rules will go to the May rulemaking hearing. At this time, it is now 12 o'clock, time for our lunch break, which will last until 1 p.m. We are expected to be joined by a guest from the governor's office, Andrew Helmsley, who will be providing information from that office for us beginning at 1 p.m. And at this At this time, we will be, or at this time, we are still under consideration for, going back into executive session, at 3 p.m. And that will be further elucidated, after lunch. Thank you.